Hi everyone, and welcome to week 2 in Health in the Public. This week we are going to be talking a little bit more about the field of epidemiology, which, as you recall, is a component of public health. So this week's objectives include being able to define epidemiology and explain the role it plays in public health, discussing the major types of epidemiological studies and provide examples of each, list and explain the limits of epidemiological studies, use the different rate equations, and examples are death rate, birth rate, in calculating data, and then find and use data sets related to public health. This week's assignments include writing in the Infectious Disease and Chronic Disease Wiki. You will have a Chapter 7 quiz. There is also a quiz called Name That Study Design, HRQOL worksheet, of course your discussion board, and this week there is a journal assignment. Now a journal assignment is just an area of communication between you and me. Other students do not have access to that assignment, and it's really a way for me to check in on you and see how you're doing in class and just to have a private conversation between you and I. So when we will open up the week 2 folder, I just wanted to point out the quizzes. So here is the Chapter 7 quiz. Again, you have 20 minutes, but if you need longer, feel free to take it, and you may retake it once. So you do have 2 times to take it. If you don't like the first attempt, you may take it again. And the second is kinds of epidemiological studies. I just want to make sure maybe you understand how to do this, but this can only be taken once because it is written in. But what you're going to do is read the question. So this question is, what type of epidemiological study is this? Smoking histories are obtained from all patients entering a hospital who have lip cancer and are compared with smoking histories of patients with cold sores. And so you would think about the different studies that you have read about, put your answer here, do that for all of the questions, and then save and submit, and there are only 3 questions. What I wanted to talk about is this HRQOL worksheet. Let me go down here for a minute so you can see what it's about. So the purpose of this assignment is to help you define and describe HRQOL, gain an understanding of what it is and what it can tell us. And what it is, it stands for Health-Related Quality of Life. And for this, you're just going to answer, so what is HRQOL, and give me a short description. And what can HRQOL tell us? So why is it important to look at this when looking at data? And then you will select 2 patterns, and I'll show you where to find that. It's on page 12. And talk about those patterns. So what do you see? How kind of judgments can you make regarding those characteristics and happy days? And then last is, what did you learn from this assignment? So let me now bring you back to Blackboard to show you where all this is located. So first you're going to use the resources provided in the folder, Health-Related Quality Days. There's a short video to help you understand what health-related quality of days. This will bring you to the CDC website, and this will bring you to a document, which I already have all of these open. So here's the CDC document, or website, excuse me, and this tells you why is quality of life important, why are we looking at it, why ask about it, what is it, what is health-related quality of life, that's what we're talking about here, and why is it important to track it, how is it measured. So this gives you just basic information on the HRQOL. Now when you open the document, it's going to open up this big document called Measuring Healthy Days. It's 44 pages, and again, you can go through this on your own, but starting on page 12, sorry, it may be a little further down, here's 11, here's 12. So starting on 12, you're going to start seeing some statistics and data. So here are the number of healthy days amongst adults with less than a high school education. Here are seasonal patterns, so healthy days by seasonal patterns. Trends in percentage of adults with frequent mental distress and healthy days. All right, so this is going to give you a couple of different healthy days measurements along with other variables, so make sure you find some that you are interested in. This is just percentage of good to excellent self-rated healthy days by demographic and health characteristics. So how many healthy days by employment status, by marital status, reported diabetes. So there are very many variables for you to look at here. And again, for the homework, you're only going to pick 2 of these. You don't need to look at them all, but look at 2 that you're interested in learning more about. So that is the Healthy Days homework for week 2. So as usual, you have your discussion board. And this is the journal area. So again, this is just communication between you and I. When you click on it, only I will have access to your journal. You will click up here where it says create journal entry and address these questions. So as you get started with this online class, I would like to know how things are going for you. Are all the assignments and expectations clear? Are you experiencing any barriers to being successful? And what can I do to help improve your learning experience? I will respond to it during the week, and it is required. It's not optional. The journal assignment is required. All right, let's go back to our PowerPoint and start talking about some of the information for this week. So there are quite a few chapters this week, and I apologize for that, but it is a lot to get through. So epidemiology is the basic science of public health. It is the diagnostic discipline of public health. It's a major part of public health's assessment function. And it looks at what are the causes of diseases. So it investigates the different causes of diseases and trends of these diseases. What are the effectiveness of medical and public health interventions? And it's considered an observational science. So what that means is they observe what's going on rather than conducting experiments to see if this treatment's better than this treatment. So it's considered an observational science. And what they're looking at specifically is who is getting the disease. Is there a certain part of the population that's getting the disease more? Are there specific areas that are getting the disease more? So who exactly is getting the disease? When did they get it? Where is the disease occurring? And then from this information, epidemiologists can infer why this disease is occurring at this moment to this particular population. In terms of epidemic surveillance, they look at, is this endemic or is this an epidemic? Is this a notifiable disease? Are they recognizing new diseases coming into the area? And this is increasingly important with the threat of bioterrorism. Is this a man-made disease? Was this released here purposefully? And so they have a lot of responsibility on their plate when we see emergence of new diseases. When there is an outbreak, epidemiologists conduct an investigation. First, they verify the diagnosis. Then they construct a working case definition. So what is going on? What is the disease? Why is there an outbreak? And they look for cases systematically. There's active surveillance. Who is getting infected? Why are they getting infected? What are the risk factors? So they ask the who, the where, the when questions to describe the epidemic by person, place, and time. And they also have to consider the incubation period, which means from the time I get exposed to the time I get sick. And they look for common sources of exposure. When we look at epidemiology and chronic diseases, now remember, chronic diseases more often tend to be behavioral related and not caused by a pathogen. So for these, epidemiologists now have to look for risk factors as it relates to behavior or environment, could be where I'm living. They're looking for long-term trends. And so, for example, there's heart disease, which is the leading cause of death in the United States. In your textbook, go ahead and read about the Framingham study, which started in 1948. Regarding lung cancer and smoking in the early 1950s is when they started identifying a link. And that was done through the British physician study and the Hammond-Horn study in the U.S. Okay, chapter 5, epidemiologic principles. So epidemiology is also the study of the distribution and determinants of disease frequency in human populations. And so one step first to define the disease. So death is more often easy to determine, and death certificates have to state the cause of death. Some diseases may need blood tests or a stool culture to verify the diagnosis. But some diseases are pretty hard to define, and as you can see here, SARS is on here. And I don't know if you know, but SARS and COVID are related. And so COVID is also difficult to determine. If you remember when it first came, it was hard to determine which were COVID. And then sometimes definition changes as more is learned. So this is before your time most likely, but when AIDS first became a thing, it was called AIDS. You have AIDS. What they later discovered is that really you have HIV, which is the virus that causes AIDS, but what it really is a collection of diseases that occur with people who have HIV. And so what they saw were specific diseases that only occur in these people with HIV. There was a specific type of pneumonia, and I don't know why everything else is leaving my head right now, but there were a collection of symptoms related to HIV. They look at disease frequency. So how many people with the disease and relate that to the population at risk. So they're not looking at the entire population of healthy people, but the population specifically who is at risk in this population. It's called the PAR, number of people with the disease against the population at risk. The PAR is the denominator, so the number of the population at risk. It could be the total population, the exposed part of the population, it could be a gender, an age group, but whatever who is considered at risk in that population. And there's two ways to measure frequency. One is incidence, and this is the number of new cases being found. The second is prevalence, and prevalence is the number of cases, period, new and existing. So usually incidence is used for studying causes of disease, but prevalence is also studied. When we look at disease frequency, if a cause or risk factor increases, what you will also see is an increase in incidence and prevalence. If the ability to diagnose increases, you will also see an increase in incidence and prevalence. But prevalence depends on incidence and prognosis. What I mean by prognosis is what is the outcome? If the disease just makes you sick but doesn't kill you, then prevalence and incidence are going to be very tightly related. If the disease is highly lethal, meaning once you get it, you die, and it's spreading like wildfire, what you're going to see is a high number of incidents, a high number of new cases, but a low number of prevalence because people are not living with the disease. We look at the distribution of diseases, so who's getting it, what are their characteristics, when are they getting it, and where are they getting it, so the neighborhood, the community where they live. And then the determinant, so why is it being distributed as it is? What can we learn from how it's being distributed? And then what are the risk factors specifically to that population? Epidemiologists also look at the human population. They observe humans in contrast to biomedical sciences, which look at experiments on laboratory animals or even humans sometimes. Epidemiologists really observe humans. And remember, it's an observational science. There are different types of epidemiologic studies, and this is that test question, so 3 test questions. So pay attention to this part and reread it in your book. But the goal really for epidemiologic studies are to determine what's the association or relationship between an exposure and a disease or other health outcome. And it may be prospective or retrospective, maybe an intervention study, a cohort study, or a case control study. An intervention study is the closest thing for epidemiologists to an experiment. They look at two groups, the experimental group, who gets the intervention or exposure, and the control group. And they watch them over time and compare the outcomes. The experimenter chooses who is in which group, so it's not a double-blind experiment, which I'm not going to really get into, but just realize that the experimenter knows who is in which group, and the two groups should be as similar as possible so that the intervention is the only difference between the two groups. So that is called an intervention study. There are two groups, an experimental group and a control group. They're observed over time to see what the impact is. Ideally, a randomized double-blind placebo control is ideal. I'm not going to get into it. It gets a little more involved. You can look it up. Pharmaceutical companies conduct many clinical trials for new drugs. There was a huge physicians' health study that was done, and what they found is that aspirin can prevent heart disease, beta-carotene can prevent cancer. There was a field trial of polio vaccine in 1954, and then there was the Kingston-Newburgh study of fluoridation to prevent tooth decay. A cohort study are for situations when doing an intervention would either be unethical or too difficult, and it's considered to be the next most accurate. So this is where you choose a large number of healthy people, collect data on their exposures, and track outcomes over time. The only difference from intervention between this and intervention is that people kind of choose their own exposures as they navigate through life. So you're not putting them into a group or anything. So examples of large cohort studies were the Framingham Heart Study, the Nurses Health Study, the British Physician Study on Smoking and Lung Cancer, and the Hamilton Study on Smoking and Lung Cancer in the US. A case control study, now this is for people who already have a disease, and what you do is you have two groups. So people who already have a disease, people who do not, a healthy control group of individuals. I try to match them up as close as possible so that you have people who have the same income level, same age group, things like that. And what you do is you're going to interview them all and ask for their previous exposures. And for this, then you're looking at patterns. So are all the people in a lung cancer group, are they all saying that they smoke cigarettes? And all the people in a healthy group saying they never smoke cigarettes? And then it kind of leads you to think that there's some sort of association maybe between smoking and lung cancer. Right? So you're looking at two groups of people, one that have a disease, whatever disease you're looking at, and then one that don't, and looking at their behaviors and their lifestyles to see the impact. This is fast, it tends to be cheap, but it's the least accurate approach. So chapter 6 talks about what are some of the issues with epidemiology. So the problem with studying humans. In an intervention study, the subjects may not follow what the prescribed behavior or intervention throughout the study period. In cohort studies, sometimes it's hard to isolate what factor is responsible for a health difference. In case control studies, the control group may not be truly comparable, or maybe they have errors in self-reporting behaviors. And in all studies, one must worry about people who drop out or you lose track of throughout time. There are other sources of error as well. So random variation between people. There could be co-founding variables that you don't know about. So what other variables or risk factors are impacting the outcome of the study? There's biases. There's selection bias, meaning the people that I chose to be in the study, maybe by me choosing a particular type of person, has biased my study. Reporting bias, what I choose to report on this study, right? It's filtered through my brain and I naturally have biases. Or even recall bias. What do I recall? And sometimes when people are self-reporting health behaviors, they're going to make themselves sound better than they actually are. So they're going to recall healthy behaviors and maybe not the unhealthy behaviors. When we think about validity to results, there are factors that lend or take away validity. Is there a strong association or relationship? Is there a dose-response relationship? So the higher the dose, the better the response. Is there a known biological explanation? Is it a large study population? Generally, the larger the study, the more accurate it is. And are there consistent results from several studies? So if several studies looked at the same thing and they're finding consistent results. For example, there was a hormone replacement therapy conducted, 2 major studies. They found conflicting results. So what do you look at, right? If you have 2 studies looking at the same thing that have different results, it's really hard. The clinical trial is really the gold standard of scientific tests. The results of the cohort study for the hormone replacement were confounded by factors that made women who were taking the hormone replacement therapy healthier even without the therapy. There are also ethical issues when we talk about studies. So think about the Nazi experiments on humans. There was the Tuskegee syphilis study in the United States. And so as a result of some of these older studies, there are new rules. One is informed consent. Does the person know what is being studied and they have knowledge of what is expected of them and they are able to give consent? There are also institutional review boards that look at the study to make sure that it is ethical and moral. And then there's also people who make sure that there is not a conflict of interest by medical providers who stand to make a profit. So for example, if I made this new drug to cure, and I'm studying my drug to cure headaches, I might show that my drug cures headaches because I have an invested interest in it curing headaches because I will then get rich, right? So that would be a conflict of interest. The conflict of interest in drug trials. So again, like drug companies are required to conduct these randomized controlled trials on any new drug before it can be approved. Harmful side effects have frequently become obvious after drugs were approved. And there's sometimes evidence, not that surprisingly, that the drug companies suppress negative findings when they conduct studies on their drugs. All clinical trials must be registered in advance in a public database, so you can look up the results of clinical trials. When we think about all of this, we must think about statistics. So it's the numbers that describe the health of a population, and statistics is how these numbers are interpreted. So most science is of probable nature. It's ongoing. Studies may contradict each other, but the science of statistics can help quantify this degree of uncertainty or help put it into perspective. And statistics and probability tend to go hand in hand. So this is like the probability of what usually happens. And it's reported using a p-value. When we look at a p-value of less than 0.05, this means that the results are significant, meaning that the study is more valid than not. But when you look at it, what it's saying is that really there's still a 5% chance that the result is wrong. 99%, 95% that it's right, but still 5% that it's wrong. So it's this idea of this law of small probabilities. There's also a number to show the power of the study. The probability of finding an effect is large or small. And then there's statistics of screening tests. So examples of screening are like mammographies, HIV tests, newborn screenings. Looking at sensitivity, so how sensitive is the test to finding what you need it to find, and how specific. And you want to make sure that we're limiting false positives and false negatives. So oftentimes you'll see in epidemiology this idea of rates. And they relate to raw numbers to a population. So what are the birth rates? How many out of 100,000? Mortality rates. How many people are dying out of 100,000? And then sometimes the crude rates are just the raw numbers, the raw rates. And sometimes they're adjusted and age adjusted. So it could be between ages 20 to 25 or over 45. Or it could be group specific, gender, for example, ethnicity, religion, occupation. Other calculated statistics include life expectancy and then years of potential life lost. So for example, if life expectancy is 80, it's a little higher, but I'm keeping it 80 for easy. and I die at 40, my years of potential life lifespan would be 40, right? Because I'm expected to live to 80, but I died at 40. Also, risk assessment and risk perception. So for well-known risks, those can be calculated from historical data, smoking cigarettes. For poorly understood risks, many have to make assumptions, and the more assumptions you make, the less statistically relevant it is. And I believe we just spoke about this last week, but this idea of this cost-benefit analysis. So costs are often easier to calculate than benefits, right? So the cost of a program is easy to calculate, but the idea that I'm not going to smoke or I'm not going to drink, well, what's the actual dollar amount that goes with that? That's definitely harder to figure out. And then our last chapter is assessing the health of a community. So what kind of material do we look for research? When you look at research, you're going to look at birth certificates, death certificates, notifiable diseases, and other vital statistics. Oftentimes, the local governments will transmit this information to states or to the National Center for Health Statistics, which is part of the CDC. And there are national surveys that are conducted every once in a while to get the health pulse of communities. As you know, we just had one, but we have the national census. And they try to look at age, race, ethnicity, income. It's conducted every 10 years. Another one is the American Community Survey that's done in between, which is an ongoing basis and provides information about housing and health insurance. There are national surveys, such as the National Health Interview Survey. One you may remember taking is the Youth Behavioral Risk Factor Survey. But again, these are just done throughout time to get an idea of where we are in terms of health. Data collection with surveys is generally imperfect. It's hard to be perfect. The census is the most accurate because there's such a big effort into getting people to answer those. Information technology increases accuracy and availability of surveys. Confidentiality of data is that your information remains private and confidential, and the government has to safeguard the information to protect individuals. The use of the data may involve removing identifying information on individuals, which would be your address, your name, date of birth, social security number. This concludes our presentation for week 2. Have a wonderful week, and if you have any questions, please do not hesitate to contact me.